Hello, my name is Claire, and today I will be presenting a narrated case review for Richie Firkins. Richie Firkins is a 5-year-old Caucasian male. He'd been attending kindergarten for 2 months when his teachers and parents had, trouble with his behavioral issues and decided to reach out for help. So early on, he would have frequent temper tantrums at school and home. He would scream, bang his head, hit other people, and his parents noticed that they started increasing when he started kindergarten at school and at home. So he would have about 5 to 6 temper tantrums at school and home per day. So he would often, he would refuse to sit at his desk for more than a few minutes. He had a hard time staying still, rarely paid attention to the teacher. And his parents and his teacher both agreed that it was getting worse and causing considerable disruption at home. They described that they had to cancel vacations. They were unable to take him on social outings just due to his behavioral issues and fear of, judgment by others. They frequently had to leave him at home to avoid these temper tantrums, to protect others from his behavior, is what they said. So after, dealing with this for about 2 months, they decided to call the local university to get help. So starting with some history, the symptoms appeared when he was 2 years old. They noticed that he was withdrawn, not particularly interested with interacting with his family, his brother. He didn't enjoy being held when he was younger. He wasn't interested with relationships with other children, including his brother, and just had difficulty having relationships with his peers. The other children often feared him, and due to his temper tantrums. And he never really developed an interest in doing things independently, like cleaning himself and brushing his hair. So he would throw temper tantrums when anybody would try to intervene and help. He also had a severe language delay. His communication was primarily in gestures, crying, temper tantrums. He engaged in repetitive and ritualistic behaviors. He would often rock back and forth, flap his hands, spinning objects. His parents noted that he never played with his toys appropriately, or they weren't even toys. He would just play with them. He was very rigid, liked things to be done exactly the way he wanted them to be. Dinner had to be a certain way, the blinds had to be down, and he would often just not meet expectations at school or at home for sitting still or following instructions. So he was prescribed Ritalin when he was dealing with intense inattention and hyperactivity, and those behaviors actually decreased. Richie comes from, an affluent home with educated parents, a loving family. He attends an excellent school, and the family does not have any history of developmental disabilities or emotional disorders. So in order to formulate a treatment plan and some goals for Richie, his parents and teachers noted that they had the most difficulty coping with his behavioral problems. Often his temper tantrums would result in him, banging his head on the floor, screaming and hitting others. And so they wanted to kind of identify and teach Richie how to communicate his needs. So they observed him at home and at school. They observed his parents and teachers, and they observed that he would he would have temper tantrums in order to get what he wanted or needed and to avoid work that he didn't want to do. So, he would throw a temper tantrum when he wanted food, or to kind of rearrange his environment back to normal, hit the way he liked it, and when somebody would ask him to do a chore. So they also observed that his parents were kind of reinforcing and perpetuating these behavior problems. So the next goal was to teach him new, more adaptive ways to gain access to what he needs without having a temper tantrum. And this is particularly challenging because Richie had not developed any speech. So instead of communicating vocally, they decided that they would kind of essentially create a communication book instead of having him communicate vocally. So he would touch a picture of what he wanted, like food or to have the blinds set a certain way. And then after he touched the picture, he would receive that reward. His parents and teachers were notified on how to not contribute to reinforcing Richie's temper tantrums. His parents wanted to console him when he was throwing temper tantrums, but unfortunately, he'd learned that by engaging in these problem behaviors, he could, get what he wanted. So his parents were enforcing, and his teachers were reinforcing the bad behavior. One aspect of his treatment that I found particularly interesting was the concept of functional equivalence. So both his tantrums and his new way of communicating, his communication book, served the same function for him. So he essentially, was able to, pick which was easier, pointing to the pictures or throwing a tantrum to get what he wanted. And he learned that, using the book and using the pictures, he could get what he wanted. And once he kind of learned the benefits of that, he was definitely motivated to learn more things. And that's not to say that his treatment didn't go without complications. Some of Richie's temper tantrums did reappear in the first week of treatment, and his behavioral issues and temper tantrums were essentially remained unchanged in his music and gym classes. So the teachers asked and kind of received some hands-on training how to prompt Richie to use his communication book. And at the end of treatment, his temper tantrums were completely manageable with his teachers and parents. After, they had been reduced to a level that the parents and teachers felt was manageable and they could tolerate, they discontinued treatment. But, his parents and Richie was encouraged to contact therapists if any other further problems arose. But by the end of treatment, his tantrums were pretty infrequent, and he no longer banged his head. He no longer screamed. His parents, felt pretty confident that he wasn't going to hurt himself or others. They were able to take him out to dinner, bring him on shopping trips. He actually seemed to enjoy spending time with his family. His peers no longer avoided him or feared him, and he ended up being placed into an integrated class for his first grade with, students with special needs and, general students in the first grade. So overall, he'll still have significant symptoms and some deficits in social and learning. He still has, many symptoms of autism spectrum disorder and ADHD. He still engages in some of the ritualistic behaviors, still struggles with difficulty with attention. and learning new things and making friends will probably always be difficult for Richie, but giving him better tools and kind of the mechanisms to satisfy his needs without having these behavioral problems is a huge step, and it'll definitely be a journey. And moving on to some of the thinking critically questions. The first one, given clear evidence for the strong role of genetic, neurological, and biological factors in ASD, what justifies the use of behavioral treatments? I think due to the wide variety of symptoms, behaviors, and degree to which their behaviors can harm themselves or others, plays a huge role in kind of implementing and creating their treatment plan, and implementing those behavioral interventions, whether they're at school or at home. And they kind of uncover and investigate until they can find the source of the behavioral issue, and then kind of give functional strategies that can help patients cope with just daily living skills like communication, body language, social cues, interactions with others, and just advocating for themselves. And then some researchers have noted that one of the challenges can be that it's not very practical. Treatment can be very expensive, time intensive. It can be going on for a long time, and so a lot of times the treatment routes are not always practical, and families aren't always able to fit it into their schedule. So like in Richie's case, he would often hurt himself or others when he was having a temper tantrum. So in order to kind of combat those behaviors, they wanted to find out what was causing those behaviors and then give him tools and coping skills and other mechanisms to kind of help satisfy his wants and take care of his needs appropriately. And for the second question, what do you believe is the best approach to educating children with neurodevelopmental disorders within the public education system? I think, special education programs and those separate classes, they can have a lot of advantages with the smaller class sizes, more one-on-one help. May be able to offer more structured support throughout the day. There's less students to teacher ratio. And they can kind of provide a little more of a predictable environment, and one that, they may not receive as much judgment from their peers. Otherwise, there can be risks with, not necessarily risks, but downsides to isolating these students in their own classrooms. They can feel isolated from their peers, socially excluded from other kids in their classrooms. A lot of times, maybe the academic curriculum may not be challenging enough, and it can kind of send a message that these students don't necessarily belong in the mainstream classes, which, I think it would be great to give these students and students without learning disabilities and autism spectrum disorder to, be exposed to different types of behavior and have regular social interaction with their peers. And kind of a variety of, integrating full inclusion and interacting with their peers, along with, having an option for more specialized settings, prioritizing their IEPs, making sure the individual education programs and their needs are kind of tailored to, in collaboration with their special education teachers, general education teachers, and kind of collaborate to create a plan. So I found this question really interesting. What factors do you believe account for the higher rates of ASD in boys and than girls? I think there are a lot of factors. I think there are a combination of social and cultural factors that kind of play into the diagnosis, the disparity in the diagnoses. first of all, and this is just a completely personal observation, but I think girls, and I wrote this before having this confirmed in the source that I found in the related journal article, that girls learn to kind of conform and mask their differences or difficulties socially or academically from a young age. I think girls and boys are socialized differently, and in the study it says that cognitively able girls may be diagnosed with autism spectrum disorder significantly less frequently and at an older age than boys, despite there being no gender differences in the age where their parents start to notice a concern. So, as long as the child is doing well in school and socially, a lot of times it goes undetected until later on in life. It could be due to past diagnostic, criteria and practices biased towards male presentation of autism spectrum disorder, and it just hasn't been tailored toward identifying it in girls. And there's also something I found called the camouflage hypothesis, which is basically states that girls may be better able than boys to compensate for or adapt to aspects of certain difficulties with autism spectrum diagnosis. So girls in social situations especially, they either intentionally or unconsciously mask their limitations and a lot of times go undetected until later in life. And then so it was interesting. Girls are more likely to be diagnosed with internalizing conditions like ADHD, anxiety, depression, eating disorders, and interestingly, girls who received an ADHD diagnosis were on average diagnosed with autism 3 years later. So it's possible that they may be just hiding or masking their difficulties in social situations and academically. And then for this question, what do you think about the change in classification from Asperger's to just the kind of the umbrella term of autism spectrum disorder? I think in my opinion, labeling humans as, high functioning and low functioning, it's really only something we have to worry about in a capitalist society, and one that prioritizes, able-bodied workers and kind of measuring a human life by how well they conform to society's standards and social rules. I think stigma is I don't know if it's gotten, I feel like autism has kind of become more mainstream, but the stigma definitely takes the stereotype of, autism spectrum disorder with negative characteristics, and so it's kind of like a them and us separation, which I don't think is necessarily right. I think also kind of the history of the troubling history of the origins of Asperger's syndrome. It was coined by Austrian physician Hans Asperger in 1944. I think changing the diagnosis to ASD just makes sense. It doesn't place individuals into categories. There's a spectrum of abilities, challenges, behaviors, and I think I do acknowledge that people, definitely identify with the Asperger's term, and diagnosis and kind of, have felt that it's part of their identity and who they are. I think they should be free to, use whichever term feels best. I just think ignoring kind of the darker history behind Asperger's is insensitive. I think the reclassification encourages more personalized and individualized assessment and treatment based on personal strengths and challenges, and I think it actually has increased care overall.